Welcome to the ICU Management and Practice DigiConf Pain Management in the ICU. Our Editor-in-Chief, Professor Jean-Louis Vincent, will moderate the session. Our panelists include Gerald Chanques, Professor of Anaesthesiology and Critical Care, Sérgio M Pereira, Medical Doctor, and Audrey De Jong, Medical Doctor. Let us now welcome the moderator for today's DigiConf, Professor Jean-Louis Vincent.
Hello, welcome and bienvenue. This is an important topic, of course. There is a lot to say. It is a question which is raised many times a day in every single intensive care unit over the world. And we are happy to have this conversation with our three experts here. And we will welcome questions from everyone through the chat, and we will try to address all of them. But before that, we will ask each of the three speakers to give a short overview of the theme which has been assigned to him or her. And so Gerald Chanques will start. He is from, as we heard, from Anesthesia and Critical Care at the Saint-Eloi Hospital in Montpellier. And he will discuss the topic of pain assessment in the acutely ill patient. So Gerald, please go ahead.
Thank you very much, Professor Jean-Louis Vincent. Should I share my screen?
Yes, indeed.
Perfect. So,
here we go.
Yeah. Perfect. Fantastic. So thank you very much for your invitation, Jean-Louis, and thanks also to your fantastic organization team, and hello to everyone. So let's talk about pain assessment. It is fundamental, as you said, to talk about pain. It is fundamental to detect and manage pain, I would say even in critical illness, and it shouldn't be considered as a cherry on the cake, because we have to provide a humane and ethical care. And what is the cherry on the cake is that the better pain management is associated with better patient's outcome, because pain is a body alarm, and its assessment allows for better detection, associating with the global disease management, a reduction in adrenergic stress response, a better match between opioids dose and patient's needs, a reduction of sedatives and paralytics, and eventually a reduction in mechanical ventilation, duration, and length of stay. And it is why we have to provide in the modern ICU a comfort using analgesia, a minimum of sedatives and a maximum of humanity. I think that you agree with that, because it's a concept developed by Jean-Louis Vincent and colleagues.
Gerald, so maybe you could widen your presentations, go to the presentation screen, because we still have all the slides on the left-hand side here.
Okay.
Go on the presentation mode. Can you do that?
I'm trying to do that. Okay. There was
if you can't, yeah, that's good. Go ahead.
That's good?
Yeah.
Okay. So this was, the concept you developed, the ECASH concept, maximum comfort analgesia, less of sedatives, and maximum of humanity. So for the assessment of pain, you can ask your patient if they have any pain, or ask them to rate a number on the pain scale. And there's a strong difference between these two approaches, because a patient could answer, no, I have no pain, or no, do you have any pain? No. And finally give a 6 on the pain scale. And in this paper, the ICU Management and Practice, we describe several common cases where a patient would answer no, but eventually give a number. And some of them are critical. For example, this patient who underwent a surgery 2 days before, and you ask him or her if they have any pain, and they say no, and I'm very surprised because I was afraid to have a severe pain, and I have no pain on my surgical site. But when you show this scale, the patient use it rather as a CT scan from up and down, and would say, oh, I will give a 3 on my right leg. And you could make early diagnosis of phlebitis. So this scale is much more sensitive, and it was demonstrated in this study. This later scale was the most feasible scale, valid, reliable, preferred scale for the patient with the best negative and positive predictive value than other scale. And the worst scale was probably this one, which is a good scale, but in critical illness with patients who have often ICU-acquired weakness, it is very difficult to move it precisely. So there have many more false negatives in pain assessment with the simple yes/no question, and the NRS is the best scale to show positive results and to make a good diagnosis. And most of the ICU patients who follow simple comments can rate a number of on this scale, and delirium, but not intubation, is a factor associated with failure. So what's about patients who are unable to follow simple comments, for example, because of delirium or sedation? So let me read an extract from this essay on medical iconology, or on the relationship between the art of drawing and the art of medicine, written by our dean at the Medical School of Montpellier 2 centuries ago. The artist should work with physicians in order to represent all differences in the expression, especially of all diverse sorts of pain. And it's why he created 2 centuries ago a fine arts museum at our medical school. And you can see Milou of Croton beaten by a lion with the typical picture of pain. 2 centuries later, the gold standard to assess pain in the modern ICU is a behavioral pain scale that you can use during a procedure, but also at rest. And it is now recommended to prioritize the pain management over the sedatives and to treat pain before increasing the sedatives, to reduce the use of sedatives and the duration of awakening and weaning from the ventilator. So in this very short algorithm, in the orange boxes, we have what we ask for the patients who are able to communicate, and the green boxes are the behavioral pain tool, the plan B, and the red boxes are for the patients who have no behavior, for example, the patients receiving paralytics. So we have to use electrophysiology, but mind that the simple vital signs and the monitor are not very reliable in critical illness. And now there are many new electrophysiology tools. such the Analgesia nociception index. And when the ANI decreases, this means that the parasympathetic tone decreases and the sympathetic tone increases, meaning that there's an adrenergic stress response. And the ANI, in fact, detect the heart rate change inducing by the breathing. And we look at the bispectral indexes changes during tracheal aspirations with paralytics and just after recovering from paralysis, and we compare it to the ANI. So the two left boxes are the bispectral indexes changes, and we can see on the two right boxes that the ANI is much more consistent and reliable, and could be a basis for further studies to better assess pain during paralysis. And in some patients, this one who is awake for a very long ICU stay, he developed absolutely no behavior and a severe depression. You can put the ANI, and if it is very low, that means that the parasympathetic tone is very low and the sympathetic tone is high. You could consider giving analgesia and look at the increase of ANI. So we could enter the brain to detect some suffering, but using it case by case. So to summarize, in most of the patients in the modern ICU with the minimum use of sedations, the patients can follow simple commands, and we can use a patient's self-report that it's the very gold standard. The plan B, in the case the patient could not follow commands, you have to use behavioral tools, and case by case, only in case there are absolutely no behavior, case by case, we could consider using electrophysiology. Thank you.
Thank you very much indeed for a nice presentation, and we will certainly have questions. We already have some questions there, and I'm pleased to say that we have more than 150 people watching us right now and following these discussions, and they are from all over the world. So it's going really very well. I think it's better, Gerald, to leave the questions for the end, and I will ask Dr. Sérgio Pereira to continue. He's from the University of Toronto in Canada, and speak about sedation, analgesia, and respiratory drive in mechanically ventilated patients. Sérgio?
Hi, everyone. First of all, thanks for the invitation. Let me share my screen here. I hope everyone can see it. So first of all, thanks for the invitation, Professor Jean-Louis and everyone else that is involved. And I'm quite anxious to be here with this panel of experts, Audrey and Audrey De Jong and yourself and Gerard. I hope I can keep up with it. First of all, I don't have any conflicts of interest. And these are the few things I'm gonna talk about here today, a little bit of theory, like the guidelines, what the actually guidelines say about sedation and pain management in the ICU and what we're actually doing. Talk a bit about the physiological consequences of sedatives, specifically the cardiovascular effects and the depression of their central nervous system, leading to depression of the respiratory drive and diaphragm and other and its effects on the diaphragm and other respiratory muscles. The new concept of lung and diaphragm protective ventilation, which has just showed up lately in the literature, and some alternative approaches to treat a reduced diaphragmatic weakness. So the current guidelines, or the latest guidelines, the one that I'm citing here, was published in 2018. Basically 40 people, which included 4 critical illness survivors, and they issued 37 recommendations. Of course, I will not go through all of them, but I'm just gonna pinch select few of them. And what they say eventually was, what they suggest eventually is that propofol and dexmedetomidine should be preferred over benzodiazepines. They don't make a statement. There's no specific statement making anything that saying anything that propofol would be superior or inferior to dexmedetomidine. And they also suggest the use of adjuvant opioids to treat pain. But what we're actually doing at the bedside, it's so in this paper in 2019, in 5 ICUs in Peru, they analyzed almost 1,400 patients in 20,000 ICU days. And they did see that these patients, most of the 25% of the patients by day 4, they were taking 1 gram of midazolam, and then roughly by day 7, the cumulative dose of fentanyl was almost 17 milligrams, the median. So we are using a lot of benzos and opioids, and earlier this year. Luz and colleagues, they sent they published this paper in Annals of Intensive Care. I responded actually to this questionnaire when I was still back in Brazil. Actually, they were asking about how we are managing pain, agitation, sedation in ICU patients. And what they came up with is that for pain management, fentanyl and morphine, they're still the most prevalent ones, and Tylenol is just the 3rd one. And dipyrone is the 5th, and tramadol would be the 4th here. And the use of alternative non-pharmacological strategies is used in less than half of the patients, or less than half of the ICUs. What they saw as well, what they reported is that how we were sedating these patients under mechanical ventilation. So you can see that midaz is more than 80%, and followed by propofol and dexmedetomidine. And the same when we're dealing with moderate to severe ERDS, and with patients with septic shock, midazolam is always the first one, followed by fentanyl and propofol. And this picture only changes when we are looking at non-invasive ventilation. And that's when dexmedetomidine is more used, and then haloperidol and quetiapine. So whenever we are looking at pros and cons of sedatives and analgesia, of course, we're all looking to treat pain, anxiety, and achieve some ventilator synchrony. But we also have the adverse effects of sedatives, which is vasopressors, the depression of the central nervous system, and increased length of mechanical ventilation. And what would like in reality, of course, would be the balance between these two. And then I think that this is the reason why we chose to put this table, and basically to show that, like, all the drugs we give to sedate patients, or most of the drugs we give to sedate patients and to treat anxiety, they do cause some sort of cardiovascular effect that we usually treat with pressors and fluids, and that wears off usually when we turn off the sedation. Now, whenever we depress the central nervous system and consequently we depress the respiratory drive, then we can see that this leads to intubation. If the patient is already intubated, this prolongs the mechanical ventilation and eventually leads to diaphragmatic weakness. Now, the control of sedation, the link between sedation and control of breathing, it goes through several different mechanisms, right? So they're suprapontine, they're mechanic, they're inflammatory, mechanical, and biochemical outputs, and all this taken together, they influence how your respiratory drive works. And of course, if you're depressing the respiratory drive, then you're likely to have some muscle atrophy. Now, I think that there has been concerns over diaphragm atrophy ever since 2004 when ventilator-induced diaphragmatic dysfunction has been described. So I brought two papers, both by Gallagher, which they showed, okay, perhaps, not perhaps, but diaphragmatic atrophy, it is an issue, and it is associated with prolonged mechanical ventilation. This was an analysis of 200 patients. And then later in 2019, they actually did the mediation analysis, Gallagher and colleagues, where they saw that diaphragm thickness is associated with prolonged mechanical ventilation, complications with acute respiratory failure, and increased length of stay in the ICU. So after that comes the whole concept of lung and protective mechanical ventilation. And I think this connects really well with sedation and pain, because at some level we want to achieve a ventilator synchrony, but and control respiratory effort, because we do know that excessive, or at least some believe that excessive respiratory effort is detrimental to patients. But if you give a lot of sedation, if you treat it very aggressively, and then you oversedate the patients, then you will have diaphragmatic weakness. So they came up with this idea of achieving respiratory homeostasis, lung protection, diaphragm protection, so that we could improve patient outcomes. And so there comes, along with this strategy comes some ideas to avoid excessive respiratory efforts or diaphragm disuse, right? So Maury and colleagues, they tried putting patients, they assessed the respiratory drive and the muscular pressure in patients weaning from ECMO. And the more you sweep off CO2, the lesser, the lower is the muscular pressure. Durdin and al, they proposed another strategy, would be like, okay, let's keep the patients deeply sedated, but let's titrate a rocuronium infusion so that we can decrease the transpulmonary pressure. Earlier this year, we published this paper in Anaesthesiology where, okay, let's try blocking the phrenic nerve with a bolus of lidocaine. And we saw that we saw a reduction in pendiluft in pigs, and we saw a reduction in driving pressure, not only in pigs, but also in humans. So this might be an alternative to avoid oversedation and to achieve ventilator synchrony. Now, this was just a proof of concept study, but all of these studies are physiological studies showing alternatives. Now, the last thing I'm going to talk about is about phrenic nerve stimulation. Back in 2016, Reynolds and colleagues, they saw that if you stimulate and you try to synchronize the respiratory effort with phrenic stimulation, you could increase diaphragm thickness. And then earlier this year, Dress and colleagues, they published this paper in the Blue Journal, where they actually saw that diaphragm bracing did not reduce the length of mechanical ventilation, or did not increase the mechanical ventilation free days, but it did increase the maximum respiratory pressure. So again, it's an alternative, and perhaps this could be beneficial in future trials. So this take-home message is sedatives are the most common drug in the ICU, and there's a fine-tuning between the desired effects and complications. So we need to keep in mind that over-sedation and over-analgesia, they will have consequences for patients. I think that at some point our shift will likely move to lung and diaphragm protective ventilation. This has become an issue lately that we need to address at some point. And I think that novel approaches, we need to at some point start focusing on that. I don't know if we need to do more peripheral nerve block, do more phrenic nerve stimulation, or perhaps try to investigate a bit more the effects of phrenic nerve block. Thank you very much.
Thank you very much. That's a very nice presentation that covers quite a bit on sedation, of course, not only on analgesia, but it's very interesting, and we will certainly come back to the novel approaches and and the difficulties in finding the right doses of analgesic and sedative agents. These are excellent points. So let's move to the third presentation. We have more than 180 participants now, and I remind you that you can send your questions either via the Q&A button or via the chat button, and we will be happy to look at your questions. So I think Audrey De Jong, who is professor of anesthesia at the University of Montpellier, will continue. I see Ambre Cuny there, but it's Audrey De Jong who presents the specificities in obese, acutely ill patients. Thank you, Audrey. Go ahead.
Thank you very much, Professor Vincent, and thank you very much for the invitation. Thank you for all the editorial staff of ICU and management, and especially Samna. And yes, I wanted also to thank Ambre Cuny, who did a very nice work of thesis, still not published, on the subjects. That's why I put her picture. And of course, I thank my masters, Professor Gerald Chanques and Professor Samir Jaber. We are all from the Montpellier University Hospital. So we are going to talk about pain management in patients with obesity. So when we look at the World Obesity Atlas in 2020, we can see that there is an increase of the obesity rate worldwide. And I live in Europe, in France, so I can see that in 2020, the rate of obesity in women is around 25%, and it will increase until 30% average in 2030. And we can see a similar predicted increase in the men. And you can see, I know there is the participants from all the world, so you can see your country and the rate of obesity that you can expect. And of course, this prevalence is also increasing in ICU, not only in the general population. As you know, the WHO classification for obesity separated several obesity classes, class 1, class 2, and class 3, with a BMI of more than 40, which means a very severe obesity. And the overall risk of disease depend also on the weight circumference. So we can see that an android obesity will be very different from a gynoid obesity. So one of the main messages regarding pain management in patients with obesity is that all the patients with obesity are not the same, depending on the fat distribution and also the lean body mass. So finally, what is the pharmacology in these patients with obesity? We will see that it's quite complicated. So we have an increased fat mass in almost all the patients. And regarding the lean body mass, it can be whether increased or decreased. And sometimes there is a hidden sarcopenia in these patients. Regarding the heart, there is often an increased cardiac output with also an increased volume of distribution. And in ICU, there is a risk of insufficient fluid resuscitation. Regarding the kidney, at the beginning of the obesity in young people, we can see a glomerular hyperfiltration, so more elimination of the drugs, and then it can go to a chronic kidney disease, and in the acute setting, an increased risk of acute kidney injury. The liver has also some attempts, and often there is a non-alcoholic fatty liver disease with consequently altered drug metabolism, and often these patients experience dyslipidemia. And regarding pharmacokinetics, it is often altered but highly variable according to the type of the patient. So when we assess pharmacodynamics and pharmacokinetics in patients with obesity, we can say that it is very difficult to predict. So when assessing the pharmacodynamics and kinetics of a drug. It was a very nice review published this year in Critical Care. You have a methodology to follow. First, you select your medication, then you do an exhaustive literature search, and you assess several variables, decision framework, outcomes, pharmacokinetics, adverse effects, and physicochemical properties. Then you do the literature analysis, and then you can provide dosing recommendation according to this literature. So which weight is assessed when we are talking about drug pharmacology? To simplify, we have 3 body weights. First, the total body weight. It is the real body weight of the patient. Then you have the predicted body weight. It is the ideal, also called ideal body weight. And it can be calculated using very simple formula. In men, the height minus 100, and in women, the height minus 110. And then you have the adjusted body weight, which is not the same, but which is close to lean body weight. And this adjusted body weight takes into account the increase in lean body mass and also the increase of volume of distribution. So it's higher, for example, than the predicted body weight, but lower than the total body weight. So finally, which weight should we consider in patients with obesity? Regarding analgesics, our topic today is pain management. So regarding opioid, what we can say it is that first, we have to use ideal body weight or sometimes adjusted body weight, but never using total body weight. And then we do a titration and incremental dosing according to the response to our analgesics. Regarding non-opioid analgesics, we don't need size descriptor recommendation, and standard doses would apply as, for example, acetaminophen or nefopam. Regarding ketamine, it is the same than opioid. You can consider ideal or adjusted body weight for the initial dosing. So what we can summarize is that we don't need at the beginning to give higher dose of painkillers in patients with obesity than in patients without obesity. And what we know also, it is not sure, but there is some literature about it, the patient with obesity will have a lower perception of pain. There are several hypotheses to explain the lower perception of pain. You have a mechanical hypothesis. The stretching of the skin due to the excess fat would lead to a decrease in fiber density and therefore a pain threshold. The endocrine pattern is also modified in patients with obesity, with increased galanin receptors that may modulate pain threshold, higher beta endorphin, and also the presence of exosome from adipose-derived stem cells that could attenuate adipose inflammation and therefore decrease the level of pain. And also, there would be a central dysregulation with higher central pain threshold in this population. So to summarize, the pain management specificities in critically ill patients with obesity. First, we have to assess pain, as Professor Chanques underlined, and use NRS for communicative patients and behavioral tools such as BPS for patients unable to communicate. There is no specificity compared to patients without obesity, of course. Then, regarding the pathophysiological characteristic of a patient with obesity, he has an increased distribution volume and a modified clearance half-life. We saw the modification of the renal function. The lipophilic medications are particularly impacted, but the metabolism is impacted by multiple additional factors. You saw the heart, the liver, the kidney, the pharmacokinetics, and especially for patients in ICU where we are providing fluid loading, antibiotics, etc. And dosing recommendation for the medication. For opioids, you can use ideal or adjusted body weights, and then do incremental dosing titrated to clinical effect. For non-opioid analgesics, there is no difference compared to non-obese patients. You can use non-weight-based dosing regimens. And for ketamine, you can use ideal or adjusted body weight. Thank you very much for your attention, and I'm available for any question.
Thank you very much, Audrey. Very nice presentation. As you say, very important problem, increasingly common in many regions of the world. So this is very important. Perhaps I could start by asking a very provocative question to each of you, just to stimulate a little bit the debate. And to Gerald first, in the order of presentations, the visual pain scales are certainly okay in postoperative patients in anesthesia, but in ICU patients, it's often more difficult to use. As you recognize, patients may be obtunded, and they may not have their glasses, they may not see well, they may be a little bit confused. I mean, you alluded to that. So my question is, are we convinced that some form of scale is better than a good nurse at the bedside that can watch the patient and appreciate the degree of discomfort of the patient? Isn't it better to have a good nurse at the bedside, Gerald?
I think it's not the nurse opposite to the tool, and both are necessary as always. But this one is very useful in critically ill patients, the ICU patients, and even in intubated patient, you can use it. And explaining the patients, it's easier for the patient to understand what you ask him or her to rate using this visual support. And even in ICU patients under mechanical ventilation, they can follow simple commands and are not delirious.
No, you said that in your presentation. I'm not asking you to repeat what you said. I am saying that in many patients, it is not very accurate because the patient may be a bit obtunded, may be a bit drowsy, may not see well, etc. So in many patients, it may work, but in many patients, it may not work so well.
Yeah, I understand that. I will really try to use it because in my experience, I can awake the patient and ask the patient to rate this. And I would say that the behavioral tools that are the plan B for patients unable to use this, when you implement behavioral tools in an ICU, it's like a double knife effect, because nurses would often don't self-report the pain or make the patient self-report their pain because they have the BPS, for example. Just look at the patient, the face is relaxed. And so, okay, probably the patient has no pain. And I think it could be a little trap with the BPS or the CPOT, and this one should be done probably most often again. And but if the patient cannot do this, no problem. Maybe his or she's delirious. Use the BPS, the plan B, and figure out why the patient is delirious. So it's a very good test for delirium detection.
Yeah, that's right, of course. Yeah. Sergio, my provocative question to you is, in view of all the deleterious effect of sedative agents, and of course we'll return to that in a moment, what about no sedation at all? Don't you think that we could do with virtually no sedation in acutely ill patients, trying therefore to preserve their muscle force and the diaphragmatic strength? What do you think, Sergio?
That's a fairly good question, Professor. I think that some centers, I think if you have a team that is properly trained and used to deal with the patients like with no sedation at all, I think that would be ideal. But most of the times when I see mechanically ventilated patients, I can remember like by heart, I would remember like in a hand that patients that I could keep them without any sedatives, without any analgesia, and then they would also have a RAS of 0, right? I remember this patient we have during COVID, and I was still back in Brazil, and he was well intubated. He stayed intubated for 10 days without any sedatives, because every time we were trying to wean him off, he would have respiratory distress and then increase hypotachnea. But the way I see it, there is, I think that there is some degree of healthcare professionals sedating patients. Like, we don't like them to be agitated. The nurses don't like them agitated. The RTs don't like them fighting the vent. So I think that at some point we're treating ourselves. So
absolutely,
this is an issue. This is definitely an issue. But no sedatives. I mean, I usually try to do this whenever I intubate a patient. I say, okay, unless there's a clear indication of sedation, I usually try to wean them off and try to watch them for a while. But I think that overall, what I could think of is that overall they do need at least a little bit of fentanyl, a little bit of hydromorphone, just to be comfortable with the ventilator. That's my perspective. And I was really impressed in when we were talking to Timothy Girard, which is one of the authors from the latest dexmedetomidine and propofol study, and they were running at 20 milligrams per hour of propofol, or 10 milligrams per hour, or even 5. And that's there. It's actually in the tables, right? So for me, that was impressive. And I asked him, how did you do this? And it was like, oh man, we had to train everyone. The nurses were there, and we were always like trying to keep as low as possible. So it is possible, but it takes a lot of training, like again, a lot of training of everyone, and a lot of, I would say it's a team effort to leave patients with no sedation. But I think it's
okay. If we can stay on sedation just for 2 minutes, maybe I can ask the others. Some people say that trying to avoid the sedative agents altogether may be possible when you have enough nurses in your ICU. But if there is a lack of nurses, nurses prefer the patients to be very much sedated, and then they can have a better life themselves. What do you think about this approach, Audrey and Gerald?
Yes, I totally agree that if there is one nurse for 3 patients, as we often have in France, the nurses clearly prefer when the patient is profoundly asleep and then very low sedation, or then absence of sedation. And if there is a less amount of work because of less patient or less severe patients, it's always easier to decrease sedation, to explain the nurse why we decrease sedation, and the nurse will be doing more rounds in the patient room, more also psychological support, because the patient will be more awoken. So we have to talk to the patient to try to understand what he's saying. So I think it improves the patient prognosis, but at bedside is very difficult to do. And as Sergio, I think it has to be a team project.
Well, again, I will be provocative, Gerald, and I will say that if the nurse prefers deep sedation to be in peace, the nurse will have to pay the price later when the patient wakes up and the patient is becoming disoriented, confused, and a little bit agitated. Perhaps there are indeed, as Audrey says, some alternatives, humane factors. By explaining the situation, sometimes the patient can be somewhat less uncomfortable with the situation. What do you think, Gerald?
I would say that there have been a strong change for the past 20 years. And 20 years ago, it was right that the nurses were used to manage a deeply sedated patient. But now we have made a lot of progress to lighten sedation, and we have succeeded in a very short or light sedation, and we explain to the nurses why it is important. And now the new nurses are more kind of discussing, of being able to discuss with the patients. So I think that there has been a change through the years and a change of culture. And what Audrey said is important, of course, to always explain to the patients. And in something, you have a physician or nurse who has a PINS ICU liberator expert. And it's a very team spirit to go forward and to liberate the patient from the ICU. And to answer also your question, of course, explaining all these situations of agitation, withdrawal, suffering, and rehabilitation that the team will have to do if the patient is too deeply and too long sedated, of course.
Okay, thank you. Audrey, my provocative question to you. We understood what you said, and of course, all of this is very important. But when I'm dealing with an obese patient, I just give drug until I have the desired effect. So I don't care really about the adaptation of the doses. I know that it's likely that I will have to use larger doses than in a smaller patient, but I give it until I get the appropriate effect. What do you answer to that?
Yes, I agree for opioids. It's as I say, titration. But for non-weight-based analgesics like acetaminophen or nefopam, often we can ask ourselves, should I give more acetaminophen, for example? Usually it is 1 gram 3 times a day. Should I give 6 times a day? The answer is no. So I think it's more useful for these types of drug. Of course, for opioids, as for other patients, finally, there are not so much specificity in this. It's the titration and the clinical effect that is important. And in patients with obesity, we have to be especially careful for respiratory depression after extubation of the patients. So maybe it's more true after a surgery, after intermediate care units, but also in ICU. The risk, because of the increased fat mass, there is a risk of opioid then rediffusing in the blood. So maybe for that, we have to be especially careful not to overload the patient with opioids.
Good points. Now, there are a number of questions about drugs or agents that we could use. And so to the three of you, are benzodiazepines really out, or do you sometimes use benzo? Or what do you recommend? If people tell you that they use benzo, do you say, no, it's terrible? Or do you say, well, yeah, but don't exaggerate. What do you think, Gerald?
I think that every ICU must have some benzos available, because today you can use Dex, but not for deep sedation because of hemodynamic side effects. You can use propofol as well, but also sometimes you have a very severe shock. And the first thing to do is to stop sedative, look if the patient always needs sedatives. And if he or she needs sedatives, consider using benzos, because they are the most robust drugs, hemodynamic side effect lies.
That's an important point indeed. Now, someone asks, how often would you stop the sedative agents? The North Americans would say every day. Some others would say very regularly. What do you do in Montpellier?
There's the systematic interruption or the systematic discussion. As Audrey said, we have to discuss every morning and night with the nurses, and someone could have a good idea about this patient to continue sedation. So what is systematic in Montpellier, south of France, is the systematic discussion morning and night, at least 2 times a day for every patient with all physicians and nurses. And most of the time, we find no good reason to continue the sedation. We stop sedation, but we stay in the bedroom to assure that there is no problem at all, and the physician should be always available for the nurses.
Very good. Yeah, absolutely. We need regular discussions, and someone on the chat underlines that after COVID, we may have less experienced nurses, and so we need to have perhaps even more discussions with them. Sergio, how do you react to this?
I think that, I mean, in my clinical practice, if I would have to pick, I would only use the midazolam as a 4th agent or as a 3rd agent. I don't use it as a 1st agent, unless I think there is a clear indication. So when I'm trying to sedate my patients, I always started with propofol and then associate an opioid. And I work in a neuro ICU for most of the time, so I associate ketamine. And then if those 3 drugs are not enough to, cause all the brain relaxation that I want and decrease the ICP, then I would turn to midaz as, again, as a desperate agent. Now, I think that lately I have been, on my clinical practice in the OR, I've been using more the SED line. And personally, I think it's a SED line, which is like EEG monitoring with just 4 leads. And I've been noticing that this might change my clinical practice in the ICU as well, because I think that most of the times we are over sedating the patients. We can see that the propofol builds up and then the patients take forever to wake up, even though we turn it off. So I do think there's still room for midaz or other opioids, but I wouldn't use it as a 1st agent. I used it a lot during COVID, but not enough.
Okay. Audrey, propofol versus dexmedetomidine, do you use them interchangeably, or do you look at the profile, the hemodynamic profile of the patient to decide one versus the other? Do you look at a time factor? How would you select between the 2? Or do you use only one of the 2, period?
I think as a first intention drug, I use propofol rather than dexmedetomidine. Because we are more used to use propofol than dexmedetomidine, and I think there is less side effects, at least when all the nurses are not very experienced. But sometimes dexmedetomidine can be used in first intention. For example, in the patient who don't need any more sedation, but they have too much agitation. And you don't want to make propofol to make them asleep, but you want just to calm down these patients and want to communicate with them. And in this case, I would rather use dexmedetomidine, of course, in absence of contraindications. And also in non-intubated patients, for example, for the night, if I want that they sleep well, we use often in the Montpellier team dexmedetomidine in this patient without intubation.
All right. All right. Someone asks if you are concerned about the PIS, the propofol infusion syndrome.
Yes, I checked, but I think it's a very infrequent event. But sometimes it occurs, and but we try to avoid too high doses of propofol and avoiding too high doses and switching, as Professor Chanques said, to midazolam in this case. We have not so much problem in practice, but we have to keep it.
Yeah. Sergio, I think you mentioned ketamine. You use ketamine regularly?
I do use I wouldn't say frequently, but again, I use it as a third agent. I wouldn't use it as my first or second agents. But I think it has its role as a third agent for sedation, or if you want to achieve some analgesia, I would run it like 15 to 20 micrograms per hour. I think it's a good agent, and it does spare a lot of opioids, and it doesn't depress the patient. So I think there are clear indications, and yes, I use it. Like my ICU is a trauma ICU, it's a neuro and trauma ICU. So yeah, we use it quite often as an adjuvant to
Gerald, do you use it regularly?
Not a lot. There's a French RCT comparing ketamine to placebo in remifentanil regimen, who reported absolutely no sparing effect on remifentanil. But in this study, they use analgesia sedation protocol based on an accurate assessment of pain using a behavioral pain tool validated, the BPS, reaching the minimal dose of opioids. So there was no tachyphylaxis in this study. And we use ketamine for the induction before intubation. And sometimes afterwards, in patients with severe depression, we use a psychiatric dose, 0.5 milligram per kilogram, for 40 minutes, 2 times a week, to have a quick antidepressive effect.
Yeah.
It's more quicker than the antidepressors.
Right. Now, Audrey, what kind of analgesic agents do you like to use? Do you sometimes use morphine, or do you think there is an advantage in using fentanyl or sufentanil, remifentanil? What kind of advice could we give to the practitioners?
That's a very good question. In our unit, we are using sufentanil for patients under invasive mechanical ventilation. And of course, for other patients without mechanical ventilation, non-intubated patient, we are going to use morphine as a standard titration. And we don't use morphine for intubated patients, as it was shown in several studies to have more side effects and also more delay in elimination and to wake up the patient quickly. Between sufentanil and fentanyl, I think there are not so much differences, even if we prefer sufentanil because of a little more rapid elimination. And regarding remifentanil, some units use it in France, but given it depends on the patient, because in patient we have a lot of pain. I think when you stop remifentanil, they are suddenly very painful, and you have to give them morphine, so it's not better. So maybe according to the type of patient for using remifentanil.
Yes, very good. And yes, someone speaks about remimazolam. Do you know that? It's a combination of remifentanil and no? Remimazolam, no? No, okay.
Probably.
I saw a case report about it, and the effects seem very interesting, but in France, it's not used in clinical practice, at least.
I didn't know about it. Okay. And what about the withdrawal phenomenon? Should we taper down and discontinue these drugs quite slowly? Is it a real phenomenon, the withdrawal syndrome? Sergio, what do you think?
I think so. I think we underdiagnose opioid withdrawal syndrome. I think so, but this is just my impression, because all the opioids, they do cause withdrawal, right? And the withdrawal, it happens really actively, and it may happen up to 5 or 7 days if I'm not mistaken. And some part of the agitation when the patients are withdrawing, like we think it's just agitation, and then we give more fentanyl. So at some point, I think it would be interesting to address, to try to use other opioids. Like why not? One thing that I ask myself, and I would ask for the other panelists as well, use more methadone, for instance, because this would probably cause treat the pain and also not cause the acute effects of.
That's a good question. Yeah.
Oh,
that's a good question. Gerald, what do you think? And it will be the last question.
Sorry, I was writing an answer on the chat. Could you repeat the question, Sergio?
What about methadone? And
it's a very good question, because we don't have the experience with methadone except for patients that are users, but different options be used in the ICU, and the question was morphine, fentanyl, etc. I think that in critical illness, we should pay attention to renal dysfunction, and morphine, methadone, we should pay attention to a risk of overdosing because of a lack of elimination, especially during renal dysfunction and morphine. So it's why we use synthetic opioids like fentanyls. But if we assess pain precisely and try to reach the minimal dose, I think everything is possible always.
Very good. There are still many questions there, but you know, it's our time is over. It's impossible to address all the questions. I think we had 3 excellent talks, and we could have quite a nice discussion about these various aspects, trying to keep it very practical. And so I'm sure that the audience will appreciate. We still have more than 150 participants right now. So I would like to thank you very much for your participation. And of course, we will continue these discussions at other times, but from now it's over. Thank you very, very much. Take care. Bye-bye.
Thank you.